Usually when we talk about a medical diagnosis, there's this underlying expectation of precision.
Oh, absolutely.
It's supposed to be like engineering. A patient comes in with a fractured tibia, the radiograph shows that jagged white line, and the attending just points at it.
Right. There's the problem. There's the code. Let's cast it.
Exactly. It's binary. It's broken or it's not broken.
Yeah. And I mean, it's comforting to have that visibility. We are heavily trained to categorize things neatly into these, diagnostic boxes based on undeniable evidence.
Yeah, but that doesn't always hold up, does it?
Not at all. The moment you step onto a labor and delivery floor, that pristine diagnostic framework, it frequently just falls apart.
It's the absolute definition of diagnostic muddy waters, especially when we're dealing with the blood pressure emergencies of pregnancy.
For sure.
And that is exactly where we are focusing our attention today. Welcome to this deep dive. We are taking a really thick stack of medical and nursing literature to demystify one of the most complex, dangerous, and, frankly, historically misunderstood conditions in human biology.
Preeclampsia.
Preeclampsia. And the mission for you, listening today, isn't to just memorize a list of clinical signs. We are going to explore a fascinating biological battle, break down some truly dangerous historical myths, and look closely at the intensive nursing protocols that are keeping patients alive on the ward every single day.
What's really fascinating here is that while this is obviously a critical topic for anyone involved in maternal care, the underlying biological mechanisms at play well, they're a masterclass in how the human vascular system works.
Yeah.
And terrifyingly, how it can adapt to essentially sabotage itself under stress.
Okay, let's unpack this, because I want to start with the clinical definition of preeclampsia, and specifically how the fundamental diagnostic rulebook had to be, well, completely overhauled just over a decade ago.
Yeah, by ACOG. It was a massive paradigm shift in obstetrics because for decades, the diagnostic criteria were incredibly rigid. Preeclampsia is, by definition, a multi-system disorder unique to human pregnancy.
Right, unique to humans, which is wild in itself.
It is, and the classic baseline was the new onset of hypertension, specifically a systolic of 140 or a diastolic of 90 or higher recorded on 2 separate occasions.
And that's presenting after 20 weeks of gestation in a previously normotensive patient, right?
Exactly. But the hypertension alone wasn't enough to trigger the diagnosis. There was this mandatory physiological gatekeeper.
Right, the proteinuria.
Yes.
Yeah.
For a very long time, that hypertension absolutely had to be accompanied by proteinuria. Protein in the urine. It was the non-negotiable gold standard.
Wow.
If a patient wasn't spilling significant protein into their urine, the clinical consensus was that they did not officially have preeclampsia. I mean, no matter how high the blood pressure spiked.
Which, looking at the modern sources, feels like a catastrophic oversight. It's essentially like relying entirely on a check engine light on a car's dashboard to tell you if the vehicle is safe to drive.
Right, completely ignoring the smoke pouring out from under the hood.
Yes, if the light is off, you just assume everything is fine. I'm struggling to understand why it took the medical community so long to realize that this specific check engine light wasn't a universal signature of the disease.
Well, if we connect this to the bigger picture, it really comes down to a fundamental misunderstanding of the pathophysiology. Researchers and clinicians were treating proteinuria as the disease itself, when in reality it was just a specific marker of renal involvement. Endothelial damage in the kidneys causes the glomeruli to leak protein.
Okay, so just the kidneys.
Right. But some patients were developing the full, dangerous physiology of preeclampsia, so widespread organ damage, neurological irritability, severe placental insufficiency without their kidneys taking the primary hit early on.
So they weren't spilling protein, and they were just falling through the diagnostic cracks.
Exactly. Meanwhile, you had other patients with mild, isolated proteinuria who remain completely stable. The rigid rule was actively blinding clinicians to severe atypical presentations.
That's terrifying.
It is, which is why the 2013 ACOG guidelines removed the mandatory proteinuria requirement entirely. Today, if a patient presents with that new onset hypertension after 20 weeks, the diagnosis is confirmed by proteinuria or any number of severe features indicating end organ damage.
And those severe features, they don't leave much room for ambiguity. We're looking at things like severe thrombocytopenia, impaired liver function, new renal insufficiency.
Pulmonary edema, too.
Right, sudden pulmonary edema, or new onset visual disturbances and headaches that simply don't respond to standard meds.
And that shift in definition dictates clinical management every single day now. Let's look at a clinical scenario from our stack. A patient arrives in obstetric triage. BP is 148/94. The urine dip is perfectly clean, but she's complaining of a severe, unrelenting headache and blurred vision.
Okay.
Under the modern definition, she is unambiguously preeclamptic, 20 years ago. A provider strictly following the textbook criteria might have charted it as gestational hypertension, given her some acetaminophen, and sent her home to rest.
Wow. That is terrifying to think about, especially knowing how quickly neurological symptoms can escalate. But, if the kidneys aren't the primary culprit, what's actually driving this systemic dysfunction? It's not just a spontaneous blood pressure spike.
No, not at all. To understand the origin, you actually have to look at how we used to explain it, because the history of this condition is filled with wild misdirections.
I bet.
Ancient physicians, dating way back to Hippocratic texts, documented pregnant women suffering from sudden catastrophic convulsions. This was centuries before the blood pressure cuff was even invented, so they had no concept of hypertension.
They just saw the end result. And the name they gave those seizures is incredibly dramatic. The term eclampsia comes from the Greek word eclampsis, meaning a flashing forth or lightning.
Because that is exactly how it presents clinically. A patient can appear perfectly stable, and then, like a lightning strike, they are thrown into a grand mal seizure.
It's an incredibly vivid and clinically accurate description of the symptom. But the medical field's attempt to explain the cause of that lightning strike led to one of the biggest historical failures in maternal medicine.
Yeah, it really did. For most of medical history, physicians were convinced the seizures were caused by a mysterious circulating poison.
Ah, yes, the classic medieval medical playbook. When in doubt, just blame a phantom poison and start bleeding people. Because what a pregnant patient really needs is fewer red blood cells. Always a flawless strategy.
Right. I mean, it sounds absurd now, but the toxemia theory dominated the field well into the 20th century.
Wow, really, that recently?
Yes. The working hypothesis was that the maternal body was being overwhelmed by the pregnancy itself and was failing to clear a theoretical toxin from the blood. The treatments were horrific: heavy purging, bloodletting, aggressive sedation.
They were desperately trying to flush out a toxin that simply did not exist.
Exactly.
I have to push back on this a bit, though.
Yeah.
Wait, if the toxemia theory is entirely obsolete and wrong, why do I still hear people use it today? I've even heard older clinicians and patients use it interchangeably with preeclampsia.
Yeah, you do still hear it. It's a linguistic fossil. It survived in the cultural lexicon even after the science completely debunked it.
Okay.
But our nursing sources actually include explicit warnings against using the term today. It's dangerous because it obscures the true pathophysiology. It keeps the focus on this phantom maternal poison when the real culprit is entirely structural.
And it originates outside the maternal organs.
Yeah.
Which brings us to the core truth, the absolute golden rule of preeclampsia, beautifully summarized in this quote from the text. The placenta is the disease, the mother is the battlefield.
I love that quote. That is the single most important reframing for any clinician. Preeclampsia is fundamentally a placental disorder that unleashes collateral vascular damage throughout the maternal body.
Okay, so walk me through the mechanics of that biological sabotage. How does the placenta essentially weaponize itself?
Well, the origin of the disease happens weeks before the mother ever feels a symptom, during the very early stages of placental implantation.
Okay.
In a normal pregnancy, specialized placental cells called trophoblasts invade the maternal uterine wall and actively remodel the spiral arteries.
Right.
They essentially strip away the muscular lining of these narrow vessels, transforming them into wide, low-resistance pipelines capable of delivering massive volumes of blood to the growing placenta.
So they're basically upgrading the plumbing to handle the demands of the third trimester.
Precisely. But in preeclampsia, that trophoblast invasion is shallow and incomplete. The remodeling fails. Yeah. So the spiral arteries remain narrow, muscular, and highly resistant to blood flow. As the pregnancy progresses and the fetus demands more resources, the plumbing simply cannot deliver. The placenta becomes chronically ischemic, it's starved for oxygen and incredibly stressed.
And hypoxic placenta doesn't just quietly fail, it goes on the offensive.
It does. It initiates a massive biochemical panic response. This was the brilliant breakthrough in the 2000s, spearheaded by researchers like physician-scientist S. Ananth Karumanchi.
Right.
They discovered that the stressed, underperfused placenta begins shedding anti-angiogenic proteins directly into the maternal bloodstream. The primary culprits are SLT1 and soluble endoglin.
And the literature describes these anti-angiogenic proteins like microscopic sponges, which makes so much sense. You have these sponge-like proteins flooding the maternal circulation. What exactly are they soaking up?
They are hunting for and neutralizing two critical molecules, VEGF and PLGF. The maternal endothelium, so the lining of the blood vessels, desperately requires continuous signaling from VEGF and PLGF to remain healthy, relaxed, and intact.
Got it.
When the placental sponges soak up all the available VEGF and PLGF, the mother experiences widespread, catastrophic endothelial dysfunction.
So the blood vessels effectively lose their structural integrity. They become leaky, they constrict, and they start malfunctioning systemically.
Exactly. That widespread vascular breakdown is what finally explains the multi-system nature of the disease. It's not a targeted poison.
Right, the plumbing is deteriorating everywhere at once.
Everywhere. In the renal glomeruli, the hepatic sinusoids, the cerebral vasculature, understanding that SFLT1-PLGF pathway is what finally transformed preeclampsia from a mythical toxemia into a precise molecular mechanism.
Which is incredible.
Mhm.
But since these sponge-like proteins are flooding the entire vascular system, the collateral damage isn't just going to look like a textbook headache and hypertension. It can wear a disguise.
Oh, absolutely.
Because I was looking at the clinical case studies in our stack, and one of them really threw me off. A patient in her late third trimester presents to the ER with intense right upper quadrant abdominal pain and severe vomiting.
Right.
No headache, no visual changes. Why would a blood pressure disorder masquerade as a bad gallbladder?
Because the vascular chaos has localized heavily in her liver. You are describing HELLP syndrome, which is a severe variant or complication of preeclampsia.
Okay. First detailed by Dr. Louis Weinstein in 1982.
Yes, and it is the ultimate diagnostic chameleon. HELLP is an acronym. H for hemolysis, EL for elevated liver enzymes, and LP for low platelets.
It's a perfect storm of red blood cell destruction, hepatic ischemia, and consumption of platelets as the body tries to patch up all those leaky blood vessels.
And if a triage nurse or physician develops tunnel vision, it is terrifyingly easy to misdiagnose. They see abdominal pain, nausea, and vomiting, and their brain jumps to acute cholecystitis, viral hepatitis, or even severe gastroenteritis.
And if they don't immediately check her blood pressure, pull a complete blood count for the platelets, and run a comprehensive metabolic panel for the liver enzymes.
They will miss the HELLP syndrome entirely until she ruptures her liver or seizes.
That is so dangerous.
It is. That's why modern nursing education hammers home the concept of systemic pattern recognition. You cannot rely on a single vital sign.
Right.
You have to look at the hematologic system, the hepatic system, the neurological system. A patient can have a relatively borderline blood pressure of 135/85 and still be in a life-threatening HELP crisis.
Here's where it gets really interesting, though. We've established that the ischemic placenta is the root cause pumping out these anti-angiogenic proteins.
Yes.
Right? So logic dictates that the definitive cure is to get the placenta out of the body. Deliver the infant, deliver the placenta, disease over. But the literature is extremely clear that this is a dangerous assumption.
It is perhaps the most dangerous assumption in obstetrics.
Yeah.
Removing the placenta is the only way to halt the primary disease process.
Right.
But the danger to the maternal brain and organs does not instantly evaporate the second the placenta drops into the basin. The structural vascular damage is already done.
Wow.
Yeah, and it takes days for the maternal body to clear those circulating SFLT1 proteins and repair the endothelium.
Which sets the stage for postpartum preeclampsia. A patient could have an entirely uncomplicated pregnancy, a smooth vaginal delivery, get discharged home with her newborn, and then be readmitted to the ICU 5 days later, actively seizing.
The physiological lag is deeply counterintuitive, which is why it catches so many families completely off guard.
I can imagine.
Preeclampsia can develop de novo or suddenly exacerbate up to 6 weeks postpartum, though the highest risk window is the first 7 to 14 days.
That puts an immense amount of pressure on discharge education. The nursing staff isn't just handing over a swaddle and some formula.
No, definitely not.
They have to aggressively drill these warning signs into the parents' heads. Severe unremitting headaches, scotomato or visual changes, right upper quadrant pain, sudden pitting edema. It's a vital safety net.
It truly is, because the triage protocols rely entirely on the patient recognizing that their headache isn't just sleep deprivation, but a neurological emergency.
So we are dealing with a chameleon disease that can strike even after the baby is out,
Yeah.
driven by this cascade of endothelial dysfunction. How on earth do you manage that on a labor ward without risking both the mother and a premature fetus? The primary cure is a brutal trade-off.
It's the classic obstetric dilemma. Let's say you have a patient presenting with severe preeclamptic features at 32 weeks of gestation.
Okay.
If you induce labor or perform a cesarean right now, you eliminate the source of the maternal disease, but you are forcing an incredibly premature infant into the NICU with all the associated respiratory and developmental risks.
Right.
If you attempt expectant management to buy the fetus more time to mature, you are rolling the dice that the mother might suffer a hemorrhagic stroke, hepatic rupture, or an eclamptic seizure at any given moment.
You need a medical intervention that buys you time, something that stabilizes the maternal central nervous system and prevents that lightning strike seizure while you figure out the delivery timeline. And that brings us to the MAGPIE trial.
Yes. Published in The Lancet in 2002, the MAGPIE trial is one of the most consequential pieces of research in maternal health.
It's massive.
It really was. A massive international randomized controlled trial involving over 10,000 women across 33 countries. The objective was straightforward. If we administer intravenous magnesium sulfate to women with preeclampsia, does it effectively prevent the progression to eclampsia?
And the results were staggering. It cut the risk of eclamptic seizures by more than half, significantly reduced maternal mortality, and did so without demonstrating major short-term harm to the fetus.
Exactly.
It solidified magnesium sulfate as the undisputed global gold standard. But reading through the pharmacology notes, there is a massive clinical misconception about how magnesium works that we absolutely need to clarify.
Oh, yes. It is the most common pitfall for medical and nursing students. Magnesium sulfate is administered for one specific indication: seizure prophylaxis. It is not an antihypertensive medication.
It's so easy to make that mistake. You
Yeah.
have blood pressure emergency, you see the nurse hanging a high-alert IV drip, and you naturally assume that drug is going to bring the pressure down.
But the mechanism of action is completely different. Magnesium acts directly on the central nervous system.
Okay.
It competes with calcium at the presynaptic terminals of the neuromuscular junction, effectively blocking the release of acetylcholine. By doing that, it profoundly depresses neuronal excitability and raises the seizure threshold.
So it's basically calming the brain down.
Exactly.
Oh.
Now, it does have a very mild transient vasodilatory effect, but it is entirely insufficient to control severe hypertension. For the actual blood pressure, providers must rely on targeted antihypertensives like IV labetalol, hydralazine, or oral nifedipine.
Got it. And managing this magnesium infusion is incredibly intense. The nursing guidelines categorize it as a high-vigilance medication because the therapeutic window is remarkably narrow.
It is a razor-thin margin between seizure prevention and iatrogenic harm. And the crucial physiological catch is that magnesium is almost exclusively excreted by the kidneys.
Wait, but we just spent the first half of this deep dive establishing that preeclampsia frequently destroys renal function.
Yes, that is the terrifying catch-22 of the magnesium tightrope. You are continuously infusing a CNS depressant that relies on healthy kidneys for clearance into a patient whose renal glomeruli might be actively failing due to endothelial damage.
Wow.
If the kidneys stop filtering, the magnesium rapidly accumulates in the bloodstream to toxic levels.
I was reading the bedside protocol for this, and it's a brilliant escalating assessment loop. The nurses are basically acting as human lab monitors.
You really are.
The first reliable clinical indicator of magnesium toxicity isn't on a screen. It's the loss of deep tendon reflexes, or DTRs. If the nurse strikes the patellar tendon with a reflex hammer and gets absolutely zero response, the drug is building up.
Right.
If it goes unchecked, the next stage is respiratory depression and eventually cardiac arrest.
Mm.
It's literally a real-time, hands-on protocol directly preventing a life-threatening complication.
That's why hourly urine output monitoring is strictly enforced. The absolute minimum threshold is usually 30 milliliters per hour.
Okay.
If the Foley catheter output drops below that, it's a glaring siren that the kidneys aren't clearing the drug. The infusion has to be stopped, and they keep the direct antagonist calcium gluconate taped right to the IV pole or sitting on the bedside table, ready to push if the patient stops breathing. It is highly regimented, labor-intensive care.
Which logically leads us to the final section of our deep dive,
Yeah.
the global perspective and the current clinical debates.
Mm.
The MAGPIE trial proved that magnesium sulfate is a chief, highly effective, life-saving drug. But if safely administering, it requires one-on-one nursing ratios, continuous fetal monitoring, and strict hourly assessments.
This raises an important question. How does that translate to health systems that simply don't have those resources?
Exactly.
Well, it translates to devastatingly unequal outcomes. While the medication itself isn't expensive, the infrastructure to deliver it safely is not. Preeclampsia remains one of the leading causes of maternal and perinatal mortality globally.
It's tragic.
And beyond maternal death, it is a primary driver of medically indicated premature birth and severe fetal growth restriction, because that damaged ischemic placenta is starving the fetus of nutrients.
And we don't even have to look globally to see those disparities. The literature is extremely clear about the severe inequities right here in the United States.
The data on maternal morbidity in the U.S. is stark. Black women face a significantly higher risk of developing severe preeclampsia and, tragically, a much higher rate of mortality from its complications. This stems from a complex web of systemic issues: delayed recognition of atypical symptoms, implicit bias leading to dismissed patient complaints of pain or headaches, and unequal access to high-acuity maternal care.
It is a massive health equity failure.
Yeah.
Which is why the current debates in the field are so heavily focused on prediction and prevention, rather than just reacting to the emergency.
Let's talk about the aspirin debate first.
Sure. So we have solid evidence that initiating daily low-dose aspirin, typically between 81 and 162 milligrams before 16 weeks of gestation, can meaningfully reduce the incidence of preeclampsia in high-risk populations.
Okay.
This includes patients with chronic hypertension, a history of preeclampsia, or certain autoimmune conditions.
But wait, if a cheap over-the-counter pill prevents a catastrophic placental disease, why is it even a debate? Why isn't it in the water supply for every pregnant patient?
Because the debate hinges on the numbers needed to treat versus the numbers needed to harm. Aspirin inhibits platelet aggregation. It's a blood thinner.
Right, of course. If you implement universal prophylaxis for every single pregnancy, you are exposing millions of healthy, low-risk patients to an increased risk of hemorrhagic complications for a statistical benefit they likely didn't need. Refining the exact screening algorithm to find that perfect balance is an ongoing clinical argument.
That makes sense. The second major advancement involves those anti-angiogenic proteins we discussed earlier, the SFLT1 and PLGF biomarkers.
Yes, this is the frontier of diagnostic precision. Several health systems are now utilizing blood tests that measure the ratio of SFLT1 to PLGF.
Oh, wow.
It allows clinicians to accurately predict which patients are likely to develop severe features in the next week and which ones are safe to send home for expectant management. It takes the guesswork out of the clinical presentation.
That's incredible.
It is. But again, the criticism is rooted in equity. These assays are expensive and access is highly fragmented, meaning the most vulnerable populations often can't benefit from the predictive technology.
So what does this all mean for you, the listener, especially if you aren't actively charting on a labor ward? Why does the biology of the placenta matter to the general public?
It matters because the single disease fundamentally shaped the entire infrastructure of modern prenatal care. Every time a pregnant patient attends a routine checkup, gets a blood pressure cuff inflated on their arm, and provides a urine sample, those mundane, ubiquitous rituals exist almost entirely to intercept this specific silent disease before the lightning strikes.
It really puts the prenatal timeline into perspective. To recap our journey through the stack today, we established that preeclampsia is not some ancient maternal toxin, but a complex multi-system disease originating from a hypoxic stressed placenta that unleashes vascular chaos.
Exactly.
We saw how the diagnostic rulebook evolved to look past just proteinuria and focus on global organ damage. We explored how the disease can disguise itself as abdominal pain and HELLP syndrome, or ambush a patient weeks into their postpartum recovery. And we broke down the intensive pharmacology of the magnesium tightrope.
It is a profound testament to the evolution of obstetrics moving from bloodletting and purging to mapping targeted molecular pathways and executing precision bedside monitoring.
It really is. But I want to leave you with one final, slightly provocative thought to ponder. We know that a stressed, failing placenta possesses the raw biological power to essentially hijack a mother's entire vascular system, simply by shedding these microscopic proteins into her bloodstream.
Right.
It creates systemic chaos. But if the placenta wields that kind of immense overriding communication power when things go wrong, it makes you wonder, what kind of subtle physiological signals, commands, and structural tweaks is the placenta constantly communicating to the maternal body during a perfectly normal pregnancy that we haven't even begun to discover yet?
Oh, that's a great point.
The real lightning might just be the incredible hidden authority of the placenta itself. Thank you for joining us on this deep dive. Keep questioning, keep learning, and we'll catch you next time.